Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, and the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential. Hello, and welcome to another show of Senior Care Confidential. I'm joined with my host, Joe Alch.
Hello there.
Hi.
Good afternoon.
And today, Joe, we're going to be talking about how to reduce hospitalizations and readmissions. And this is something, I come from a research background, and this is something that we studied a lot. And I know as a nurse, you probably see this quite a bit too. And we found that there's a number of things to address, and we have these hospitals and skilled nursing facilities, and they have regulations, and they got to produce the 87-page, discharge paperwork, which nobody reads, right? It's like a lot of legal speak, and, it's really just a checkbox for a lot of things. And so what I have found is with training other seniors, including patients of ours, is that if we can drill it down to like the top few things that are easy to remember, then we can actually get probably 80% of the way there. And so that's what we're going to discuss today.
Well, it's interesting. I have so many clients that I'll ask, did anybody review these discharge orders with you?
Right.
What? Did you bring anything home from the hospital? Did they give you any paperwork? I don't think so. Then they'll dig through their bag and, oh yeah, is this what you're talking about? Well, and they're just overwhelmed.
Yeah, and it's in perfect order. There's no crumpling of the sheets. It's never been opened.
It's never been opened.
Right. And with hospitalizations and even readmission, rehab hospitals, like the most crucial time after a discharge is that first 7 to 10 days. And so what a lot of people don't realize is, and we get this quite frequently, where we'll go out and see a patient, and so before the hospitalization, before the bad thing happened, whether it was a fall or a chronic illness that it exacerbated or whatever, it doesn't really matter what the reason was. But before they go to the hospital, they got one medication list. And then they go to the hospital and things are kind of awry. So the physicians in the hospital will modify the meds and they'll be on a different set of medications. They'll go to the rehab center with another med list, and then the rehab center, the hospitalist rounding at the rehab center will also, modify their meds. So they get home, and I go out and see them. They're like, Ryan, I've got 3 or 4 med lists, and I'm not sure which ones to take.
They'll have bags of meds and have no idea, and the family's confused. They're like, we don't know what mom's taking. So it is so important to know what they're on and what they're supposed to be taking to keep them healthy.
Yeah. And so because we see this so frequently, it's like, okay, we probably should do a show on this and highlight the top things. So the good news for the audience is there's just really 4 things that we've drilled down that say, hey, if you can get these 4 things, we call them 4 keys to managing chronic illnesses. The first one is what we just discussed, is you need to have some sort of a master list. We call it a reconciled medication list, but some sort of a master list that has all the medications and ideally your supplements too, but at least if you have the prescription medications on there from all of your specialists. So when I worked for the post-acute research company, what we found was that the average senior has 1 primary care doctor and 2.3 specialists.
Wow.
And so there's a lot of meds that are kind of flying around, and even within the same, and this was a shocking thing, even within the same hospital system. So here we have Baylor or UT Southwestern or THR or whatever, within the same hospital system, a lot of times the doctors aren't updated or don't know that there's been modifications to medications. And I know you just recently had a scenario where there was like a doubling up of meds.
Yeah. So I had a patient who was having horrible hallucinations, and so bad she had convinced herself they were real. She couldn't sleep by herself. She couldn't sleep at all. She did not want to be left alone. She's covered her microwave with dish towels. She's covered her windows with towels. I mean, she's just terrified. So going through her med list and going through her meds, I found that her primary doctor prescribed a medication with enteric coated, and it said the name of the medication plus ENT. And then her specialist ordered the medicine without the ENT on the prescription. So she assumed she was taking 2 different things, when actually she was doubling up on her medication. And our normal dose, one of the side effects is hallucinations. So basically, when you're doubling, of course, you're going to have these terrifying hallucinations. Yeah. So right now, we are just easing her off that medication. We're adding some medicine for anxiety. And so we're just titrating and scaling up and down. And within a week, she's doing better. So it's
And how,
just,
so for the audience too, how long was she doing this
she was
before
doing
somebody
this for
realized?
6 months.
So 6 months,
And
because
she-
the doctors hadn't communicated, hey, I've also sent this. She was confused on the medication. And so now we got 6 months of terrifying hallucinations where she's essentially barricading herself in the house with towels and those kind of things.
Well,
Yeah.
and my son is a physician at a big hospital in Ohio. And I asked him, I said, Christian, why is it that the primary doctor isn't consulted, say when somebody's in the hospital, or a neurologist, a family goes to a neurologist, and the primary doctor is not consulted on what medication change there is? And he said, there's no time. There's no time to do that.
Yep.
And there are the My Charts, which are great, but is anybody reading those My Charts? And who is on top of the My Charts?
Yeah. I think everybody's, all of us that work in healthcare, our schedules are so compressed and they're so tight. There's a lot, in addition to the patient care side of it, there's the regulatory stuff that we've all got to deal with. So it's almost an impossible task to keep, if you're the physician or the primary doctor, like keeping updated on this stuff. So,
well, and I have a question too on Nexus. And so I know we're on meds, but just talking about that discharge paperwork, a lot of times I see patients that are on Medicare home health, they may not hear from anybody for a week. So what do they do? How many days is a normal grace period to wait to hear from the Medicare home health agency?
Okay. So assuming that the discharge planning process was actually a plan and that the patient hasn't gone home without a plan in place. So let's assume that the discharge planner, the case manager, whatever you want to call him or her in a facility, is usually we prefer that they start communicating with us a few days prior to discharge so we can kind of get an idea of when they're coming home, because our policy is we want to see them the day after because we see all of this stuff. So the other issue with them going home is the dietary stuff changes, right? If you've been in a hospital for a couple weeks and then a rehab hospital for a couple weeks, you're used to eating different foods than what you're going to be exposed to at home. And then you've got the whole home environment thing. So there's all that stuff. So anyway, to answer your question, we want to be out there within 24 hours of a discharge from any kind of a facility, whether it's rehab, SNF, or hospital. But it really depends on how communicative the case manager is at the hospital level though too, because we have seen them.
How do you know? I mean, how do you know that they've made that had that communication, or if they just sent over a fax?
Yeah, this is where you as the patient or you as the POA or the son or the daughter want to make sure
manager.
that you're communicating with that caseworker, the case manager, the social worker, whoever that might be that's doing the discharge planning process, that you've communicated with them, hey, what's the next level of care going to be? Who needs to be involved? Have those orders been sent? The other thing we run into too is the equipment isn't delivered. Like it's not ordered, it's not delivered. So there's equipment needs, there's medication. That's the other thing you need to follow up with too is, do we have the medications prescribed that we need so we can get those at home? So I would communicate heavily with the case manager.
Well, and that's for me as a care manager, and not everybody can afford a private concierge nurse or care manager, but those are the things I ask, what meds, what can she take home? Yep. Has everything been called in? Is there something that has to be called into a different pharmacy?
Right.
When can we expect a call from the home health?
Right.
All those questions that people don't they just assume they've got a packet, so it's all done, and it's not always all done.
Right. And if the orders were all set, for pharmacy, DME, which is medical equipment, or home health or hospice or whatever, assuming all things were done on the front end effectively, the patient or the family member should be contacted ideally before they discharge, but worst case, I'd say within 24 hours. If nobody's come to see you or called you to schedule, then call back the case manager or your doctor or your care manager in terms of like Joy Care. Make sure that they're aware of it so they can rectify that. So that's number one. Number one is making sure there's a master reconciled medication list that everyone agrees to. By the way, that person who's maintaining that has to be the patient or a loved one, right? And they're updating the specialist. Anytime a medication changes, the doctor's all informed versus the doctors having to call themselves. You're going to make sure you update the doctors so everyone knows.
Absolutely. So when they leave the hospital, they've got a med list. Make sure a family member, loved one, care manager, someone calls the primary doctor to let them know what meds they're on.
Correct. Correct. Now, ideally, if they're working with a home health company, we are sending that stuff over. Like we're calling the doctor going, hey, we got some medication issues here. We're not really sure which ones they're supposed to be on. Ideally, we're getting them set up with that physician visit within 7 days because there usually have been some medication changes. And then we get a master list kind of from there.
That's great.
So,
and pharmacists are always looking for contraindicated medication. And my particular patient that was doubling up, she got one prescription from one pharmacy, one from CVS, one from Walgreens. So that was where I think the Walgreens physician pharmacist would have said, hey, we're getting two of the same thing. But this particular patient, we drove to 3 different pharmacies. She couldn't remember what pharmacy she was using.
Yep.
And so that is, can be a big problem.
That's right. That's right. The more things, the more doctors, the more pharmacies you bring in, it adds to complexities, right? Mm-hmm. So the second one, in addition to having a master medication list, we want to have some way of tracking that we actually took the meds. Because I'm 45 years old and there are days I have forgotten to take my supplements or my vitamins or whatever. And I'm at lunchtime like, did I take that today or not? So if I'm in my 70s and 80s, there should be some way of verifying that you actually took what you were supposed to be taking. So you can do that through those pill packs.
It's 7 letters, pill box.
Yes.
They're great.
There are local pharmacists who will do it for you. I think Amazon just literally bought pill pack a couple of years ago, whatever. So there's options out there, or you could go the techie route and you could just get one of those plastic ones, it's got AM and PM in it and you pre-fill it. And that way you can always verify that you're actually taking the stuff you're supposed to be taking.
Well, and I have another client that has trouble sleeping and the first thing I do, hey, how'd you sleep last night? Joe, I slept terrible. I look at his pill box and he didn't take his PM medicines.
Yep.
And so, that's right.
Yeah.
And that's the thing for me. It helps me as a pill box, as a clinician, as an RN, I have that checkbox.
Yes.
I can see whether or not he's taken his meds or my patients have taken their meds.
The fun challenge is when you have someone with some cognitive difficulties. And so you may or may not know, even if you look at the pill box, you may or may not know like what's actually happened to them. So even if you call them on the phone, so I like the Alexa, there's an Echo Show device. Mm-hmm. And so we've actually had some of our families get those. And so they can actually do a video call. The device is next to the meds. They can do a video call and actually watch mom take them. Because it's one thing to get one, because they have those pill packs or pill boxes that are on a timer. And so the alarm will keep going off until you pull the little sleeve out. Well, depending on the level of cognition, they just may pull the sleeve out and then just sits there on the countertop.
Right, on the table.
So you want to verify, depending on levels of cognition, you might want to verify they're actually being ingested. But this at least gets you down the right path. So one, we got the master list. Number 2, we want to make sure that we're following that medication regimen and like tracking it. Number 3 is we want to make sure that you're monitoring vital signs or what we call key indicators. So that means if I'm diabetic, I'm tracking my sugars. If I've got hypertension or high blood pressure, I'm tracking blood pressure. If I've got something like congestive heart failure, I may be tracking my weights, because a weight gain of 2 pounds overnight or 5 pounds in a week is usually an ER visit. So you want to be able to track that stuff. And the reason behind that is because you want to make sure that the meds are actually doing what they're supposed to be doing. So a lot of good it does you if you take hypertensive meds, and we don't really know, except for the 2 visits a year or 3 visits a year you see the doctor, what the blood pressure is.
Well, and now with blood sugars, with the Libra, it's a little device that's in your arm and it checks your blood sugar all day as often as you need it. And I think that's awesome because you're not having to prick your fingers anymore.
Yeah.
And there are even smartwatches can do those readings for your blood sugar. And so it's easier to stay compliant.
Yes. And they are working on some ways. I don't know how they're going to do this. They're working on some ways to make watches do blood pressure readings. I mean, they can already do oxygen levels. They can already do heart rates. They can check, like the new Apple Watches can actually check for, it's like an EKG. So they're making smarter devices that make this a little bit easier. But the point of all it is you want to make sure that there's some sort of a feedback loop that that the meds are doing what they're supposed to be doing. You've heard of white coat syndrome, I'm sure, right? Mm-hmm. So I was actually at the doctor today and I definitely have it. I'm always high when I go. And so, but what we found is interesting. There's a significant portion, we think it's about 20% of seniors who have white coat syndrome. There's another, so that's when your blood pressure rises when you see anybody, dentist, doctor, doesn't matter. There's another, we think around 20% that have the opposite of white coat syndrome. So these people, when they go see the doctor, their blood pressure actually drops. Wow. So it's fascinating. Yeah. And so if the blood pressures aren't being taken in their home where they live, the other 363 days that the doctor's not seeing them, then we don't really know what those things are really running. And so, the doctors and the practices are using their best educated guess on, hey, if you're showing up consistently high, we think you've got hypertension, so we're going to put you on these blood pressure meds. What we're running into now is that there are some people who are actually normal at home, but when they go see the doctor, they're higher, so they're on these hypertensive meds. And so I come out there and they're having falls because now their baseline blood pressure is too low, and they've got what they call orthostatic hypertension.
Yeah,
and so
because
now
their meds aren't correct.
Yes, so they're already starting low. They stand up, their blood pressure drops even further and they're on the floor, and so this becomes an issue. So again, you want to make sure that you're monitoring whatever conditions you're being treated with medications, that we're monitoring those things and making sure that they're effectively working.
And not only monitor, if you get the readings that it's off, call your doctor.
Which brings me to number 4. So number 4 is if you got the master list and you're taking the medications the way you're supposed to be doing and you're monitoring everything, what do you do when things start to go awry? Because over time, like, your body's going to metabolize medications differently. I mean, speaking of, we've talked about carbidopa, levodopa earlier today. That actually has some blood pressure issues if you've been on it for a long time. And so sometimes it just, because the length of time you've been on a medication, it can change things for you. And so number 4 is knowing how to respond to changes. And so we think of this as like a stoplight system. So you got green, which is everything's safe, not too high, not too low. Then you got yellow, which is the area beyond that, which is more of a caution zone. So if your blood pressure is too high, what do you do? If your blood pressure is slightly low, what do you do? So you can get it back to the green zone versus it getting worse and worse, and to where red zone is actually, that's a hospital stay or an ER visit or whatever. And so it's really important to know what those safe ranges are for you. Sometimes you can go by some standard numbers for that, blood pressure ranges or whatever. And sometimes the doctors actually want their own ranges because the individual patient might ride high or might ride low. And so they may tweak those ranges, and you just need to know what those ranges are. So, hey, what do I do when it's this? What do I do with this? When do I call you? When I call the doctor or the nurse or whatever? And when do I call for 911? So those 4 things are what we found have been most effective in helping to reduce a lot of the hospitalizations. So again, it's master medication list, making sure that you're following the treatment or the medication regimen. Number 3 is making sure you're monitoring your vital signs or key indicators. And then number 4 is, if everything's going smoothly, great, but if it starts to trend poorly, what do you do then?
And that's why it's so important to have a great home health company that you can call, or call your doctor, get to know the nurse, get to know the nurse's name, and call. And if they don't call you back, call them again.
Yep.
There is always somebody there that can help you.
Yeah. And this is, Medicare, they publish a lot of studies every year. And so this is probably a couple years old, maybe about a year old. I think COVID's wrecked everything on some of this stuff. But like the more normal year we had, they projected that roughly 2/3 of all hospitalizations are considered preventable. And it's an annual cost to Medicare of $17 billion a year for what they deem as preventable hospitalizations. And that's, yes, there's the medical condition stuff, which we just kind of went over. There's falls and there's injuries. It's all those things that all contribute to it. But when you're dealing with the medication side or the chronic illness side, if you do these 4 key things, we have found that there's a significant drop in the risk for hospitalizations, ERs, those kind of things.
Yeah, and I think about my clients that wind up in the ER. They're non-compliant. They're not taking their meds right. They're not eating right. They're not listening to what the physical therapist told them to do or told them not to do. So it's just so important to educate and communicate and keep educating, never stop educating.
Right. So for patients or for seniors or loved ones who have older loved ones that need some additional help, and maybe they do, maybe they don't have a home health, but they need somebody to kind of help quarterback and oversee that. This is what you do with Joy Care.
This is what I do.
How does somebody get in touch with you?
So they can reach me on my cell, 214-415-3779, or they can email me, Joalch, JOALCH, at joycaremanagement.com.
There you go.
What about you, Brian? Because you are the very best in home health.
Thank you. My cell phone number is 321-271-4052, or email is Brian, BRIAN, at nexushomehealthcare.com.
I think too, if your loved one's in the hospital and you're getting that list, play a part, ask questions. Tell me about this home health. Have you worked with them before? They usually, yeah, but do you communicate? Who is it that I talk to? If I have an issue, am I going to have a problem getting in touch with someone on the weekends?
Right.
So even families, you've got to sign consents for this home health agency, or for myself. Like, what are your hours? There's some care managers that I work not with in my company, but are in the field, and they don't answer the phone on the weekends. Well, how do you prevent problems on the weekends? You can't.
Especially in that first 7 to 10 days, which are just so crucial. Yeah.
So there's got to be somebody they can talk to. And if you don't feel you're getting the communication, then there are other options.
Yep.
And just remember, you always have a choice. The customer always has a choice.
Right. And so just make sure whoever you're working with, whether it's the doctor or the therapist or the nurse, or in your case, the care manager, make sure that they're helping you identify what those 4 things are, those 4 keys, and how to make sure you're managing those things well. And that will help keep you out of the hospital.
Thank you, Brian.
Until next time, Joe.
Until next time, take care in this heat. Stay cool. We'll see you again.
All right. Bye, Joe.